Good morning. For this recorded presentation, I'm going to talk about CK, otherwise known as creatine kinase, or the complete name would be creatine and phosphotransferase. The old name is CPK, meaning creatine phosphokinase. Right, so this is found in the muscles primarily, and it is responsible for the conversion of ATP to ADP using creatine phosphate, okay, as the main substrate. This is an unstable enzyme, so it is affected by temperature and the presence of um, ions, certain ions. So as I told you, this is an enzyme found in the muscles. We can see in this slide the chemical reaction undergone by creatine, the substrate, in the presence of CK at the pH 9.0. So that is an alkaline environment. So ATP will be converted into ADP plus creatine will be bound to creatine phosphate. So in the process, this will be able to create a lot of energy. There are three isoenzymes of CK, and they are designated by letters or by combination of letters and by numbers. So these isoenzymes are CK1, CK2, and CK3. CK1 is also known as CKBB, CK2 is CKMB, and CK3 is CKMM. So they are found in different organs. Primarily, if you see CK1, that is found in the brain. B represents brain. And then MM, this is found in the skeletal muscles, while CKMB is primarily found in the heart. So I already mentioned, okay, that they are found in the skeletal muscle, the brain, and in the cardiac muscles, but this may also be found in the kidneys and in the lungs. Okay, looking at this table, you can find that the activity of CKBB is primarily in the brain, but for CKMB and for CKMM, this can also be found in the heart, okay, and the skeletal muscles, although it's very limited in CKMB in skeletal muscles. Right, so smooth muscles, okay, activity of CKBB has been also found, like in the GI tract, so the muscles, smooth muscles of the small intestines, the stomach, the large intestines, and for the urinary bladder also. But it's primarily CKBB. Right, so clinical significance, what are the conditions associated with elevated CK activity? So one is muscular dystrophy. So this is more or less genetic disorders in males. In males that, for example, Duchenne muscular dystrophy. So what will happen is that the person would not be able to control his muscles anymore. So in that case, there will be an increase in CK activity. Of course, you expect that the isoenzyme in that case would be CKMM. In the cardiac muscles, so the significance is called acute myocardial infarction. We know this as heart attack, acute myocardial infarction. And then in the brain, there is, of course, it's elevated in cases of CNS disease and in stroke. Stroke is also known as CVA or cerebrovascular accident. So, in the predisposing factor to having this AMI or CVA is elevated blood pressure, so hypertension. In cases of neurogenic muscle diseases, so there is a problem with the um, control of the muscles because of the involvement of the central of the nervous system. For example, MG myasthenia gravis, there is a problem with the cholinesterase, which is the enzyme responsible for communicating, allowing the communication of the substance, right? So acetylcholine, um, it will lead to problem with the stiffening of the muscles, skeletal muscles. And then multiple sclerosis, that is an autoimmune disorder like myasthenia gravis. In this case, there is demyelinization of the fibers in the nerve fibers. And then poliomyelitis, so that is a viral disorder that affects the muscle, leading to unilateral atrophy. So one of the extremity, the legs, is usually um, undergoes atrophy, so it will be smaller than the other. And then Parkinsonism. So this is a degenerative disease that is affecting, of course, older individuals. Okay, wherein the person is unable to control, okay, the movement of the skeletal muscle, especially the legs and the hands. Okay, the enzyme activity, however, in these conditions is found to be normal. So even if they are affecting the nervous system and even affecting the muscles, they are found, the activity of CK is found to be normal. Okay, and also thyroid disease. So in thyroid disease, this is related to some functions of the skeletal muscles. So it's also affected, elevated. CK is elevated. Now, most of the time, the doctors would ask for CK, particularly CKMB measurements for the diagnosis of myocardial infarction. This is the first enzyme to elevate in case of acute myocardial infarction. You can see that in this graph. So the first line is representing CK and CKMB isoenzyme. So you will see that the enzyme is elevated within the first 48 hours, one of the first. Okay, the first days, the first 2 days, day one and day two. Aside from that, okay, there's also another enzyme which is AST. We talked about AST before, so this is an enzyme that is also found in the heart and the liver. Okay, it's also elevated. However, look at the size, or the how high it has reached. It's only like up to this level 3 compared to, okay, the CKMB, which is like 10 times the normal. Right. So the third enzyme that is also used for the prognosis of myocardial infarction is LD, lactate dehydrogenase. We have not talked about this yet. But if you miss the first 48 hours of acute myocardial infarction, then you can also check for LD levels. So this is useful when you miss this first 2 days of testing elevation. Right, so we can do many different tests for the determination of CK activity. So the most common is the colorimetric monitoring kinetic method. Okay, there is also direct colorimetry by converting the substrate into a coupled substance, colored substance, that you will be able to measure it. And then fluorometry, when we make use of low wavelengths light. Okay, in again, it's the same thing as colorimetry by converting the substrate acted upon by CK into a fluorescent substance, and that will be measured using this technique, but at lower. Right. So this is the principle behind the continuous method monitoring method. So this is a coupled technique. First, we have a substrate called creatine kinase, or creatine phosphate rather. Okay, and it will be acted upon by this CK, the enzyme, and this is the substrate in the presence of ADP, forming free creatine. So this is the uh, reverse reaction. As we have seen in the previous reaction, it's the opposite. So this is a reversible process, and then it will produce ATP. The ATP that was produced in the process will be made to react with glucose in the presence of another enzyme, okay, and it will form glucose 6-phosphate plus ADP. This glucose 6-phosphate that was produced in the previous chemical reaction will be made to react with a third enzyme, glucose 6-phosphate dehydrogenase, okay, in the presence of a coenzyme, NADP, and it will produce 6-phosphogluconate. And this is a colored substance. Okay, and you can do the measurement, absorbance reading every minute. Every minute. We expect that there is an increase in absorbance, okay, every minute. That is why we call it continuous monitoring. Next, electrophoresis. We can also apply electrophoresis, but this is mainly to um, identify the isoenzyme. Remember, there are three isoenzymes, and the only significant isoenzyme is CKMB. So we can use this to separate the three isoenzymes. Okay, and the medium that we can use is either agarose gel or cellulose acetate membrane. CK assay substrate, which is usually creatine. Creatine is incubated on the membrane, and then NADPH will be added, okay, and it will form bands, invisible bands yet. But if we want to visualize these bands, we can add a stain, for example, formazan, or we can use fluorescence spectrophotometry. Okay, at this wavelength, 360 nanometers. So that this is for visualization, and this is for the chemical reaction, and that is for the separation. Right, so let us look at the bands. So this is the resulting bands. The resulting bands. So this is when you stain um, the gel, when you stain the gel and you can transfer that onto a piece of paper, it will form this band. Okay, and this is the graphical representation from negative to positive, from anode to cathode. And you can see here, this is the point of origin. The point of origin, that is the pattern of migration going to the positive pole. So CKMBMM is the slowest. It remains like very near the point of origin, and then the middle one would be CKMB, and the last, which is the fastest, is CKBB. So that is this is the significant part. Right, so we can also do another technique called ion exchange chromatography. So in this case, we need a um, uh, an ion exchange um, receiver. Okay, anyway, so ion exchange chromatography. We can do ion exchange chromatography. We can do immunologic methods that is involved a antigen and antibody reaction. So we can do precipitation immunoassay like ELISA or RIA or EIA. So those methods. So you should be talking about that in mainly in immunology or in serology. Now for the specimens, we have to use non-hemolyzed serum because hemolysis can lead to a analytical error. Okay, and then storage in the freezer or the fridge may be necessary if you cannot do the test immediately. Okay, the substance CK is stable only for 8 hours at room temp, and less than 8 hours, and less than about 48 hours, okay, at 4 degrees Celsius, and even 1 month at 20 degrees negative, it should be negative 20 degrees Celsius. So the significance of storage is mentioned here. Right, quality control, we always say this whenever you do a test, okay, you have to make sure that you run it with quality control sample or control serum. This can be manufactured commercially, or it can also be produced in the laboratory using pooled serum. Now, you also have to run it with a standard, if possible, standard substance sample. Okay, and in order to check for errors, we can follow Westgard rules or other quality control rules by checking it against for example, the chart. So, and then that will allow us to uh, make sure that the result is correct. Validation of patient results, you have to make sure that the result you are giving out is really for the right patient. Okay, sources of errors. So this is just to repeat some information. So sample is not fresh. We know that it is unstable only for 8 hours, and it is affected by heat. So therefore this may lead to falsely lowered activity of CK and the presence of anticoagulants like citrate and fluoride that have anti-enzyme activity, the anti-enzyme, and hemolysis can also, as I mentioned. Okay, so hemoglobin can lead to errors in the measurement. Reference range, you can see here, this is the normal range. About 15 to 105 in males, can 10 to 80 for females. Okay, and if you look into the isoenzymes, okay, we should not be able to see any CK1, but of these, 4 to 6% would be CK2 and CK3, excuse me, about 94 to 100%. Okay, so, but this is affected also by the method, okay, and uh, the age of the patient. Okay, so they also found that, this is race dependent. Okay, in Caucasian patients, the reference interval is found to be actually higher than that of the other groups of people like dark skinned people or blacks. So sex, age, muscle mass, physical activity, race, those are certain factors that can result in physiological variations. Right, so finally we have to take note that we need to document the results of the recording is very important. Retain the record for recommended period of time. You have this in your medical technology laws. How long should we keep the records? Now, in order to prevent some of the errors that we encounter, it is recommended that we use automation. Okay, thank you.